So obviously there's a lot to know about the heart. Hopefully we get you started on that. Now let's turn to some blood clotting and lipids issues. So for blood, we can look at the complete blood count. On that, we see that the white blood count tells us about infections and various other types of illnesses. We see that the hemoglobin and hematocrit, which is also referred to as the H&H, tells us how much of a oxygen carrying capacity the blood has. The red blood count is sort of useful in some cases, but for most of us, we really just look at the H&H the vast majority of the time. Platelets are actually a way to clot blood. You can see some of the other videos actually explain this a little bit better and talk about the difference between stopping blood clotting through platelet ways as well as other forms of anticoagulation. So we've already talked about the white blood count a little bit. You can actually watch the whole video on the CBC. If you're motivated to do that, that's on my YouTube channel. Why do white blood cells go up? Well, in most cases, it's a bacterial infection, and usually that's neutrophils. Again, each one of the types of white blood cells will go up for different reasons. The white blood cells can also go down, and especially in a viral infection, the overall will usually go down, even though the lymphs will usually go up or be slightly high normal. And there's also people that have bone marrow or thymus suppression that all of their white blood counts will go down. Sometimes all of their types of cells, red cells, white cells, platelets will go down, and that's called pancytopenia. Low white cells is just called leukopenia. So what about the red blood count? We definitely look at the H&H more. Hemoglobin goes down if you're not creating it or if you're losing it. So it can be a blood loss thing or it can be a bone marrow suppression thing. If you don't have enough iron, you don't have enough folate, or you don't have enough B12, you won't produce as many cells. And losing hemoglobin is almost always a blood loss thing. There are other ways that you could be losing hemoglobin, such as hemolysis, but those are much more rare. So I usually use the 11, 12, 13 rule. A pregnant woman under 11 is anemic for hemoglobin. A woman under 12 is anemic, and a man under 13 is anemic. No matter what, you're going to have decreased oxygen carrying capacity, and those people will often be tired. Blood loss is often related to a cancer. So if you have colon cancer, you lose blood through your colon. If you have a bladder cancer, you'll actually lose blood through the urine. But you could also have heavy periods and lose blood through the uterus. So Opal Hipps, let's talk about Opal. Opal is a 75-year-old woman. She lives alone with Chester, her dog. She's got a 3-bedroom house in the suburbs. She worked as a postal clerk. She retired 10 years ago. And mostly she's not very active. She reads and watches a lot of TV. Over the past week or so, she's had a hard time walking. She's got an ache in her right leg. The right leg does seem a little bit larger than the left. It's minimally tender. It's not red. It's not abnormal in any other way. A lot of people think that when you get a blood clot in your leg, it's got to be red and very swollen. Unfortunately, not everybody gets that. So what we did was we did an ultrasound of Opal. Her primary care provider is a physician, so she saw her doctor, and the ultrasound showed a deep vein thrombosis, also known as a DVT. Now, thrombosis is a clot that forms in place. An embolus is a clot that breaks off and goes someplace else. There's actually other things that can embolize too. Air can embolize, foreign bodies can embolize, but thrombosis is something that occurs in place. Embolus is something that breaks off and goes someplace else. Now, phlebitis is actually, phlebo is the prefix for veins. So a phlebitis would be phleboitis. Itis is inflammation, so it's inflammation of the veins. So how do you treat a DVT? Sometimes we put people on unfractionated heparin. They have to go in the hospital. They have to go on a drip. We don't do that very much anymore just because nobody wants to go in the hospital if they don't have to, and the insurance companies don't want us to put people in the hospital if they don't have to. Sometimes it is necessary, but more often than not, we can treat people as an outpatient. How can we do that? Well, we can give them low molecular weight heparin, which is a shot. Enoxaparin is an example, or Lovenox is an example of that. Shot can be given either once or twice a day, depending on the dosing. But that requires giving a shot. We can't really give warfarin initially for a DVT because the problem is that warfarin actually increases coagulation for a few days before it decreases coagulation. So you really need to have somebody on some other kind of an anticoagulant. Now, the direct oral anticoagulants are relatively new, but they work extremely well. You don't need to have somebody on any other anticoagulation before they start them because they work essentially the same as enoxaparin. They work essentially by blocking factor 10A, which is one of the factors in the clotting cascade. Their direct factor, warfarin works by decreasing the production of something, and so it's a couple of days before that prothrombin decrease actually results in any decreased anticoagulation. So DOACs are a good choice. It's actually the one we use the predominantly most often now. Sometimes we're using DOACs for DVT prophylaxis in the hospital even now, although the enoxaparin is actually more commonly used, or one of the other low molecular weight heparins. We often will put somebody with a clot on bed rest just so they don't break off the clot and embolize it. The concern is that a deep vein thrombosis will break off, go to the lung, and become a pulmonary embolus. Bed rest, of course, increases the risk of clotting. So usually we'll rest them for a day or two, but we really won't substantially rest them just because we do increase their overall risk that way. So Opal had broken her femur 14 months ago. She's worried about her dog. She's 5'2". She's 149 pounds. To convert that to kilograms, you'd divide it by 2.2. So that's roughly 50 kilograms is 110 pounds. And so for each 10 kilograms, it's another 22 pounds. So she's probably somewhere between 65 and 70 kilograms. Her temperature is a little bit elevated, but not substantially. And her pulses are actually there, but a little bit hard to locate. But that's actually bilateral. Unfortunately, a lot of people will decrease their arterial circulation as they get older. That arterial decrease, the peripheral vascular disease or peripheral arterial disease is a whole nother discussion. Why did she get a clot? Well, she may have had a family tendency. There's certain types of factor V Leiden. There's a lot of things that run in families that will increase your risk of a clot. Decreased activity, well, clearly she has that risk factor. Does diet play a role? Maybe, but we're not really convinced at this point. And sometimes you get a phlebitis from trauma. I just had a patient recently that was kicked in the leg playing soccer and 2 days later developed pain, and we scanned him and he had a blood clot. Why do we worry about the DVT in the leg? We've already said that, right? So we worry that it's going to go to the lungs. So if she develops chest pain, shortness of breath, low oxygen, she can have developed a pulmonary embolus. Can you get a stroke from a DVT in the leg? Well, really, it's going to go to the right side of the heart and then to the lung usually, right? The only time you'd get a stroke is if you actually have a hole in your heart, something like a patent foramen ovale, a PFO, or an atrial septal defect. We used to think those were rare. We now think that probably 5 to 10% of the population has them. So you can get a stroke from a DVT. There was a New England Patriots player a number of years ago, Teddy Bruschi, that actually had a clot in his leg and it went to his brain. So objective of treatment is to keep the clot from moving. In longer term, we want to help the clot dissolve and prevent other clots from forming. We don't usually give a clot busting medicine because unfortunately they have fairly substantial risk of hemorrhage in other places such as the brain. And we know predictably that if we anticoagulate people, they will be able to break that clot down on their own in the vast majority of cases. So we decrease the activity, we don't massage the leg. And as I say, we really don't decrease the clot size by thrombolytics. If it was an arterial clot, we might do that or might actually surgically remove it because that would decrease the blood flow. The vein is just going to decrease the flow back to the heart. There's collateral circulation for the veins almost always. And again, sometimes we'll use heparin for the short term, but we try to avoid it if we can. So let's digress a little bit. We're talking about anticoagulation, and DVT is a common reason, pulmonary embolus is a common reason, but probably the most common reason that we use anticoagulants is something called atrial fibrillation. Now, A-fib is quivering of the atria. So basically, the atria are not producing any sort of a coordinated contraction. Because of that, the blood will pool in the atria, and the most concerning place that the blood can pool is something called the left atrial appendage. And so if you get pooling in that left atrial appendage, it's on the left side of the heart, so that if it goes shooting out of there, it's going to go shooting up to the brain. And so the risk of stroke is substantially higher in people with atrial fibrillation. So who do we treat with anticoagulation? We treat anybody that's got substantial risk. Now the atrial fibrillation itself, how do we treat that? Well, there's two real approaches. One is what they call rhythm control, which is trying to get them back into sinus rhythm. We sometimes use electricity to do that. We use a cardioversion, which is the same thing as defibrillation, except that it's coordinated with the cardiac beat. Defibrillation, you just shock them. Cardioversion actually is coordinated with the EKG and will deliver the shock at a certain point in the cardiac rhythm. The intent is to get people back into sinus rhythm. It often will do that. The problem is that if anybody's been out of sinus rhythm for any period of time, the odds of keeping them in sinus rhythm are not that great. There's also medicines that are antidysrhythmics, such as amiodarone, and they will also decrease the probability of going back into A-fib. They are medicines with substantial side effects, however. Rate control is basically when you have somebody that has A-fib, doesn't feel badly because of it, and we will keep them in a rate that is not tachycardic, because unfortunately A-fib will often cause a substantial tachycardia, which makes the heart less efficient. In extreme cases, you can actually get a cardiomyopathy from that tachycardia. I say extreme, even 110 for a prolonged period of time can do it. And we'll use a beta blocker or a non-hydro calcium blocker to slow that rate down. Who lives longer? People in rate control or rhythm control? Seems to be no difference based on the AFFIRM study. So we do something called the CHADS-VASc score. You're welcome to look that up if you're interested. If it's high enough, 2 or more, we will put people on an anticoagulant to try to prevent a stroke. We can either use warfarin or we can use a DOAC. People with mechanical valves right now, you can only use warfarin. So basically, if you remove the mitral valve and replace it with a mechanical or metallic valve, you got to use warfarin. If you use a pig valve or a cow valve, we usually put them on anticoagulation for a year or so and then take them off. And you can also, obviously if somebody's got a mechanical valve, if they have to have surgery or whatever, heparin is fine, but just for outpatient treatment, you have to use warfarin. Heparin is a medicine which interferes with the clotting cascade immediately. I believe it blocks factor 10. And the clotting cascade, of course, is this very complicated, difficult thing. Starts at 12, goes to 11, then goes to 9, weirdly, later goes to 10. That's the common pathway. There's an extrinsic pathway, an intrinsic pathway. There is no factor 6 because factor 6 was actually a duplicate of one of the other factors. The clotting cascade is way more complicated than I really want anybody to worry about, other than to know that various types of anticoagulants work in different parts of that clotting cascade. The low molecular weight heparin, the enoxaparin, that kind of thing blocks factor 10A. And basically, again, I'm not sure that you really need to know all about the clotting cascade other than to know that different types of medicines block it in different places. Coumadin actually blocks one of the factors that is in the clotting cascade, but the production of it, so that it doesn't deactivate the prothrombin that's in the system, it just slows down the production. So therefore, it takes 2 or 3 days to really kick in. So therefore, you can't use Coumadin right off. It doesn't work fast enough, as well as causing that increased coagulability for the first 24 to 48 hours. It is given orally. It's a reasonable choice for long-term therapy, although we are moved more towards the DOACs. The DOACs are relatively new medicines. They block in slightly different places. We used to worry about them because there was no reversal agent. Now there is reversal agents for all of them. I'm not going to cover that right now, but you're welcome to look those up. Be a great thing to post. These medicines, Xarelto, the advantage of Xarelto is it's once a day. The advantage of Eliquis is that it's been shown not only to decrease strokes, but also to not have any increased bleeding. A lot of people like Eliquis because of that, but it's a twice-a-day medicine. The actual effects of the two are actually pretty comparable. Dabigatran or dabigatran has kind of fallen out of vogue just because it is not quite as effective as the other two. Other components of treatment for DVT, we can do warm moist heat, you can manage the pain. Usually Tylenol is what you manage it with because you don't want to use non-steroidal anti-inflammatory medications like Advil or Aleve in somebody that's on anticoagulants. You monitor the calf size, often do daily measurements. TED stocking on the other leg makes sense. TED stands for thromboembolism deterrent stockings. You can elevate the affected extremity to help get some of the swelling out if it's swollen, and also just make sure the patient changes their position to decrease the risk of another DVT and keep their fluids up. So Opal, after her initial resting stage, increased her activity. She tried to get adequate fluids. She took her DOAC for at least 3 months and then was taken off it. She did not need to do any pro-times because she was on the DOAC. She was on rivaroxaban once a day and therefore did not need any sort of blood tests. She goes home happy and healthy. Arterial clots are obviously very different. They can cause ischemia and even infarction and death. The 5 Ps, they'll have pain, pallor, pulselessness, paralysis, and paresthesias. Lipids are, to change gears here, something that we hear lots about. Lots of patients are very interested in the lipids. It is related to clots because most clots are formed from lipids, but we usually address lipids independently based on blood levels. After somebody has a clot, you do want to make sure that the lipids are well managed, though. So what else can contribute to clots? Smoking, obviously nicotine irritates blood vessel linings. Bacterial infection, hypertension. You're not really sure why clots form, but we've got a lot of ideas of things that increase the risk. So if we decrease the cholesterol, we know that the risk of clots, including myocardial infarction and brain clots, which are the majority of strokes, are actually clots. So how do we keep the lipids under control? Well, you can try to get the amount of fat in the diet down. You can try to get people to lose weight by keeping their carbs under control. The Pritikin diet gets the fat down to about 5%. That'll get the cholesterol down more than 10%. But with most dietary interventions, you're lucky to get the total cholesterol down about 10%. Get enough vitamins, don't smoke, keep your hypertension under control, control your diabetes, and medications. So aspirin is a good medication if you've got somebody that's had a heart attack or stroke or a clot. This is now secondary prevention, and there does seem to be benefit for it. As we've talked about before, there's not really a whole lot of benefit for primary prevention. The other medicine that you can use to decrease the risk of clotting are statins. And statins are HMG-CoA reductase inhibitors. They work in a certain process in the liver, and they just basically stop the body from synthesizing cholesterol. Because they do that, they can actually cause issues in the liver or in the muscles. Their effect is decreased by CoQ10. There's various types of lipids. There's water-soluble and fat-soluble. The water-solubles are things like pravastatin or rosuvastatin. Those seem to have a slightly decreased risk of muscle symptoms. So basically, just because a person can't tolerate one statin doesn't mean they're statin intolerant. You know, you should try 3 or 4 different statins before you come to the conclusion that someone is statin intolerant. Why do we need to worry about statins? Why don't we use just a different medicine? Well, statins are the only medicines used for cholesterol that have really been shown to decrease overall death rates. All of the others may decrease cardiac death rates, but they don't decrease overall death rates, so they increase cancers or liver failure or something else that offsets. Examples of those are niacin. Niacin is a great medicine. It lowers the HDL. It increases the HDL, the good cholesterol. It lowers the LDL. It lowers triglycerides. Does decrease heart attacks a little bit, but really doesn't save any lives. It's also very hard to take because there's a lot of flushing. The non-flush medicines really don't have as much data on them. There's bile acid binding resins like Questrian. These basically reabsorb some of the bile, and a lot of that bile is cholesterol, so it decreases the cholesterol. It also lowers the blood sugar. Again, the problem with these is they don't show any benefit as far as overall deaths. They're also really hard to tolerate. Most patients get a lot of gas and cramping and just really don't like them. Other things that lower lipids, red wine, exercise. Zetia has some evidence as a supplement to statins, but really has no benefit by itself. I'm not going to talk about Repatha here. Repatha is a medicine that's what they call a PCSK9. It's a monoclonal antibody that blocks that particular substance and decreases cholesterol. It also does not decrease overall deaths, but it does decrease cardiovascular deaths. So going back to the types of cholesterol, there's LDL, which is the bad cholesterol, HDL, which is the happy cholesterol, the good cholesterol, and then the triglycerides, which are the VLDLs. Drugs of the week, lots of different things to think about. As we noted, pravastatin is a water-soluble, atorvastatin is a fat-soluble, atorvastatin is a intense lipid lowerer, whereas pravastatin is just a moderate lipid lowerer. So lots of different guidelines, lots of different categories. Just start to get basically familiar with these.